Now let us take up the next important issue, which is retinitis pigmentosa. Typically, the retinitis pigmentosa is a primary pigmental retinal dystrophy. Primary, no reason. It is a retinal dystrophy fundamentally. So you have rods, you have cones in the retina. What is involved in retinitis pigmentosa? It is the rods more than that of the cones which are involved. There is a different entity by itself called cone dystrophy, which is different from retinitis pigmentosa. But in retinitis pigmentosa, rods are the ones which are predominantly involved. What is the inheritance pattern? This is one of the favorite MCQs in the exam. So in the notes given to you, we have mentioned what will become MCQs in the exam. Okay. Autosomal recessive is the most common inheritance. It can also occur autosomal dominant. It can also be X-linked recessive, but X-linked recessive is the least common mode of transmission. Most of the times in exam, the question asked is, what is the most common form of inheritance? What is your confident answer without any shake? It is autosomal recessive is what need to be remembered. Typically, it appears in childhood, progresses slowly. Ultimately, when the person reaches the middle age, he becomes blinded. Males are affected more frequently than that of the females. And if you look at the very disease, it is almost bilateral in a good number of scenarios. And both the eyes are equally affected with the retinitis pigmentosa, which is a primary pigmentary retinal dystrophy is what need to be remembered. When the rods are affected, which kind of vision is affected, doctor? Naturally, night blindness. So night blindness is a very characteristic feature. Now, if you look at retinitis pigmentosa, there are two things. What the patient complains you as a symptom versus what you will see in the fundus as a clinical sign. Between the two, which will be the one which will appear first? Typically, the night blindness, which is a symptom, it appears several years even before the retina shows all those classical fundoscopic changes in retinitis pigmentosa is what you have to ultimately remember. So symptoms are first, critical signs will follow after a few years. It is a degeneration of the rods. The person loses the dark adaptation. By the time it is evening, he is afraid to go out of the home. The light threshold in the peripheral retina will typically increase. And quite late, the dark adaptation become affected. And when the retinal rods are degenerated, ultimately rods are mainly what, doctor? Peripheral or central part of retina? Most of the times rods are peripheral. Very peripheral means only rods. Then comes rods, cones, and ultimately in the center you have only cones. In the area of the macula and fovea. So that is the reason the periphery become degenerated first, because it is primarily a degeneration of the rods. What is left is only the central vision, hence called as tubular vision, is a classical feature of the retinitis pigmentosa. What are the changes in the fundus? This is one question very frequently asked in MD entrance. So ultimately we will give you 200 to 250 pages of ophthalmology notes. Out of that 50-60 pages, you must be in a position to revise in the last moment. And you must be in a position to bookmark right now. What to be remembered in the last? What need to be looked back in the last? Only bookmark, no underlining. We don't permit you to underline. Underlining is that obsessive compulsive neurotic phenomena to bring down the anxiety, whether we understand the subject or not. You should understand subject, You must know what to be remembered, what to be ignored. That is the whole idea of these sessions. Because information is too expressive. Typically, the retinal pigmentary changes will be around the retinal vessels, perivascular. They resembles the corpuscles of the bone corpuscular appearance, classical MCQ in the entrance. Initially, there will be in the equatorial area only. We said no. What is meant by equatorial area of the retina? You have vertex veins. If you take the retina, if you draw a circle along the place where vertex veins open, it is called equator. Center to that is called posterior pole. Outside that is called periphery of the retina. So it typically starts in the equatorial area, the pigmentary changes. And later it will spread both anteriorly towards the ora serrata and posteriorly towards the optic disc, is what need to be remembered. So doctor, if you look at the normal retina, it looks like this. And a retina where that bony corpuscular appearance is like this. And the main problem is the degeneration of the rods, is what need to be remembered about retinal retinitis pigmentosa. How are the retinal arterioles? They are all attenuated. They get buried into that pigment. Hence they are narrowed, attenuated. They become thread-like in late stages. Another favorite MCQ in the entrance. Retinal arteriolar attenuation with a thread-like retinal arterioles. Where do you see? What is your answer? Retinitis pigmentosa. The optic disc become pale and waxy, and ultimately there is a development of a consecutive optic atrophy, secondary optic atrophy. Now let us look at how it looks. Are you able to see the optic disc which is waxy and pelor? You are also able to see the attenuated arterioles. Arterioles are all attenuated. Then all that bony spicule appearance diffusely. These are the hallmarks of the fundoscopy examination of retinitis pigmentosa. Now what are the other associated features, doctor? There can be colloid bodies, choroidal sclerosis, cystoid macular edema, and one very peculiar type of maculopathy. Cellophane maculopathy it is called as. Another favorite MCQ of the examiner. Where do you see cellophane maculopathy? You need to remember it is in the case of the retinitis pigmentosa. So what kind of visual field defects? There can be a ring-shaped scotoma, which is a very typical feature. It is there along the equatorial area of the retina. And ultimately it will be spreading both anteriorly and posteriorly, and what is left is only a central vision. Hence what you have is called as a tubular vision, is what need to be remembered. Now, is there any role for electrophysiology to diagnose a case of retinitis pigmentosa? Because retinitis pigmentosa mein main symptom kya hai? Night blindness. Night blindness can be vitamin A deficiency, night blindness can be due to X number of reasons. So you must be very sure to objectively evaluate the degeneration of the retina instead of a subjective symptom based. And unfortunately symptoms are also little late after degeneration progresses to certain stage. So what is a much earlier objective way of assessing retinitis pigmentosa? You can do electroretinogram, electrooculogram. These are the two things which become abnormal. Electroretinogram become abolished, electrooculogram become, typically if you do electrooculogram, there is an absence of the light peak. So by that you can objectively assess. And the beautiness is, we should not use the word beautiness. There is no beautiness about losing vision. Important thing to remember is, the electrophysiological changes typically appear much earlier, even before the subjective or the objective symptoms on the signs on the fundus appear. So first to appear is electrophysiological changes, next become symptoms of the patient, then comes the fundoscopic changes. That's the order of progression of the retinitis pigmentosa. Now what are the associations Are there any specific subset of population with other ocular conditions who can develop this retinal rod degeneration? Yes, sir. Myopia, open angle glaucoma, microphthalmos, or if there is any posterior subcapsular cataract, these are the subset of population in which retinitis pigmentosa, instead of a genetic development, it can be a acquired form of retinitis pigmentosa can develop, because in all these people there is a development of a retinal degeneration, and that degeneration leads to rods to get affected, and that lead to retinitis pigmentosa like situation. So that is the acquired causes of retinitis pigmentosa. You should remember myopia. Okay, doc. Now there are some syndromic associations about retinitis pigmentosa, which is commonly asked in the exam. Lawrence-Moon-Beadle syndrome, what does it mean? Retinitis pigmentosa with obesity, with hypogenitalism, with polydactyly. 1, 2, 3, 4, 5, 6. Sixth finger. Who is that movie actor who has an abnormal finger? Very famous Bollywood actor. Huh? Hrithik Roshan. Okay. We'll dedicate this topic to him. So, polydactyly, you should remember Lawrence-Moon-Beadle. There can be mental deficiency, any of these can be associated. Then what is cocaine? Retinitis pigmentosa, dwarfism, mental retardation with nystagmus ataxia. What is repsum? Repsum is very interesting condition. Why? Repsum's disease is a disorder associated with the metabolism of phytanic acid. Associated with phytanic acid. So what is this phytanic acid, sir? We will anyway read in biochemistry, don't worry. But you should remember Repsum's disease is with phytanic acid. Phytanic acid, phyto means what? Leaves, green leaves. So, in these people, accumulation of phytanic acid will lead to the development of retinitis pigmentosa, along with peripheral neuropathy with cerebellar ataxia. Because of the development of retinitis pigmentosa, what will they develop? Night blindness. In night blindness patient, for giving him good vitamin A, generally what will suggest? You eat green leafy vegetables, you will say. But if it is due to the Repsum's disease, where the problem is with phytanic acid, what you should tell? You don't eat green leafy vegetables, is what you should say, right? So today only you go and ask your ophthalmology postgraduate, tell me that situation where night blindness patient you will dare to say, don't touch green leafy vegetables. If he knows this phytanic acid ka silsila, then he will correctly answer you. Okay. Now, Usher's syndrome. It is retinitis pigmentosa, ENT plus ophthalmology, complete package is Usher's syndrome. Retinitis pigmentosa plus labyrinthine deafness together. This is a typical example of a patient of Usher's with a typical bony spicular appearance of his retinitis pigmentosa. Halgren's, if you still have energy, you are not yet collapsed with too much of toxicity in the brain to remember too many things, you can still remember this, but this is not required. Usher is asked in entrances. Then Repsum you must know. Cocaine, rarely it is asked. Then you have Lawrence-Moon-Beadle, you need to remember. That's all, doctor. Then you will say, what is this, sir? Talk about treatment also. There is no treatment for retinitis pigmentosa. In textbook there will be one full page dedicated for treatment, but that is not asked in exams. They are all experimental treatments. After getting seat in MS Ophthalmology, you can read it. Okay, doc. So that's all the story about retinitis pigmentosa, our topic number 2 for today.